Hi viewers, I am Bijoy Ajayan, 2012 MBBS batch, Government Medical College, Trivandrum. In the previous episode, we have discussed about the various type of strokes, the anterior circulation strokes, as well as the details of the cranial nerves, that is 1 to 12 cranial nerves. So in this video, we will continue our discussion of the posterior circulation strokes, right? And before that, I would like to tell you something. See, as medical students, we are supposed to know the anatomy of the brainstem. And since you can see in these three figures, these are all the cross sections of the brainstem, having a lot of structures, right? So this in fact make our understanding more difficult, right? So a neurologist in Australia, his name is Peter Gates. So Peter Gates, he devised a method, a simpler method to know the brainstem anatomy. That method is also called as the rule of 4. So in fact, in reality, when we do a neurological examination, we test only a few structures of the brainstem, right? So the rule of 4 recognizes this and only describes that part of the brainstem which we actually examine during a neurological examination, right? So let us know what is the rule of 4. So you have 3 rules for that. The first rule of 4 is the first 4 cranial nerves lie above the pons. The second 4 cranial nerves, they lie in the pons, and the next 4 cranial nerves, they lie in the medulla, right? So the first 4 cranial nerves, they lie above the pons. That is 3 and 4 are situated in the midbrain, while 1 and 2 are even high above, right? And 4 cranial nerves, the next 4, 5, 6, 7 and 8 cranial nerves, they lie in the pons, while the 9, 10, 11 and 12 cranial nerves, they lie in the medulla, right? So that is one rule that helps us to remember all the cranial nerves where they arise from, right? So that is the first rule of 4. Now there is another rule, that is all the medial structures of the brainstem. I mean the structures of the medial that is present on the medial part of the brainstem include 4 M's. That is the motor pathway, the medial lemniscus, the medial longitudinal fasciculus, as well as the motor nuclei that divide the number 12. That is 3, 4, 6 and 12, right? 1 and 2 are exceptions, and 3, 4, 6 as well as 12, right? So that is motor nuclei that divide the number 12. These 4 numbers, it can divide 12, right? 3 into 4 is 12, 4 into 3 is 12, 6 into 2 is 12 and 12 into 1 is 12, right? So all these 4 cranial nerves, the nuclei, the motor nuclei are in the medial part of the brainstem, and the medial longitudinal fasciculus, the motor pathway, that is the corticospinal tract, right? And the medial lemniscus, that is a part of the dorsal column pathway. So all these lie on the medial part of the brainstem, right? And apart from these, so this motor nuclei that divide the number 12 equally, they lie in the medial part of the brainstem. All the other nuclei, whether it be motor or sensory, they lie in the lateral brainstem, right? Now, what are the lateral structures? The mnemonic is just 4S, right? That is the spinothalamic pathway, the sympathetics, the spinocerebellar pathway, as well as the sensory component of cranial nerve 5, of the 5th cranial nerve or the trigeminal nerve, right? So these are the lateral structures of the brainstem, fine. So in this case, the spinocerebellar pathway as well as the sympathetics, they do not decussate to the opposite side. So you have to remember that. So on the lateral side, you have the 4S, that is spinothalamic pathway, sympathetics, spinocerebellar pathway, and the sensory component of the trigeminal nerve, right? So that is 4S. This is the third rule of 4, right? So once again, about the cranial nerves, first 4 lie above the pons, next 4 lies in the pons, and the last 4 lies in the medulla. 4 medial structures, the motor pathway, the medial lemniscus, the medial longitudinal fasciculus, and the motor nuclei that divide the number 12. That is the motor nuclei of cranial nerves 3, 4, 6 and 12. The lateral structures, the spinothalamic pathway, the sympathetics, spinocerebellar pathway, and the sensory component of cranial nerve 5. So always remember, the rule of 4 is recognizing only the structures that we actually examine during a neurological examination, right? So keep that in mind. So we will see this in our further discussion. how to practice this, right? So now we will start the posterior circulation strokes. So this is the posterior circulation. We will once again revise it. You have the two vertebral arteries that join to form the basilar artery, right? And the basilar artery finally bifurcates into the posterior cerebral artery. And you have the anterior spinal artery that is coming from the vertebral artery just before it joins to form the basilar artery. And you have the posterior inferior cerebellar artery that is coming from the vertebral artery in 50% of the individuals. In the rest, it comes from the basilar artery. And you have the anterior inferior cerebellar artery and the superior cerebellar artery. So these are all supplying the cerebellum, the superior cerebellar artery, the anterior inferior cerebellar artery, as well as the posterior inferior cerebellar artery, right? So this is the posterior circulation. So posterior circulation is connected with the anterior circulation through the posterior communicating arteries, right? So first of all, we will come to the posterior cerebral artery, right? What happens if there is an occlusion of the posterior cerebral artery, right? So the posterior cerebral artery occlusion, usually it results from an atheroma formation or an emboli that lodge at the top of the basilar artery, right? And there are two clinical syndromes which are commonly observed with the occlusion of posterior cerebral artery. See, the posterior cerebral artery, we can divide it into two segments, that is the P1 segment as well as the P2 segment. The P1 segment is the proximal segment. The P2 segment is the distal segment. So distal to what? Proximal to what? So this is the point. See, this is the point. This is the junction where of the posterior cerebral artery with the posterior communicating artery, right? Proximal to this junction is the P1 segment and distal to this junction is the P2 segment, right? So the junction is the posterior cerebral artery with the posterior communicating artery. Proximal to it P1, distal to it P2 segment, right? So I have told you two clinical syndromes are there that is associated with the occlusion of posterior cerebral artery. These include P1 syndrome, that is due to occlusion of the proximal segment or the P1 segment of posterior cerebral artery or the penetrating branches. So usually from the proximal segment you can see the penetrating branches, right? See, this is two vertebral arteries, basilar artery, posterior cerebral artery, and this is the P1 segment, this is the P2 segment, and you can see the penetrating arteries that are arising from there, right? So due to its occlusion of the proximal segment of posterior cerebral artery or its penetrating branches, right? So that is P1 syndromes. And then you have the P2 syndromes, that is due to occlusion of the P2 segment, that is distal to the junction of the posterior cerebral artery with the posterior communicating artery. Fine. So first of all, we will see the P1 syndromes. So what are the P1 syndromes? You have the Weber's syndrome, that is involving the anterior cerebral peduncle, right? This is the anterior cerebral peduncle, right? Anterior cerebral peduncle as well as the third cranial nerve, right? So what happens? There will be an ipsilateral third nerve palsy with contralateral hemiplegia. Why? Because the corticospinal fibers, they are going to decussate at the medulla, right? This is the midbrain, and at the medulla they are going to decussate, right? So you will be having a contralateral hemiplegia with ipsilateral same-sided third nerve palsy because the third nerve is involved, right? So that is Weber's syndrome. So ipsilateral third nerve palsy plus contralateral hemiplegia. This type of hemiplegia is called as the crossed hemiplegia, right? That means there is an ipsilateral cranial nerve palsy plus a contralateral hemiplegia, right? So hemiplegia, so cranial nerve palsy on one side and hemiplegia on the other side. That is called as the crossed hemiplegia. Now this crossed hemiplegia is strongly suggestive of a lesion in the brainstem, and if at all you find a crossed hemiplegia, then you can say the brainstem as the site of lesion. Fine. So that is the importance of crossed hemiplegia, right? So that is Weber's syndrome. Then another syndrome that you have is the Claude syndrome, right? Claude syndrome is affecting the red nucleus as well as the superior cerebellar peduncle, right? The superior cerebellar peduncle is connecting the cerebellum with the midbrain. There are three cerebellar peduncles, that is superior, middle and inferior cerebellar peduncles, right? So this is connecting the cerebellum with the brainstem, that is superior with the midbrain middle with the pons and lower with the inferior cerebellar peduncle with the medulla, right? So once the superior cerebellar peduncle as well as the red nucleus is involved, you will get a clot syndrome, right? So what are the features? Of course, the third nerve is also affected. There will be ipsilateral third nerve palsy and contralateral cerebellar ataxia would be there, and abnormal movements, that is contralateral chorea, tremor, athetosis would be there. Fine. So that is clot's syndrome. Now, what happens if the perforating branches are involved, right? The penetrating branches which I have told you. You can see these branches, right? So occlusion of the perforating branches of the thalamic as well as thalamo-geniculate arteries, right? So these are the thalamo-geniculate arteries. So occlusion of the perforating branches of thalamic and thalamo-geniculate arteries results in a syndrome that is called as the Dejeron-Rousey syndrome, right? So what is the special feature of this syndrome? That is, the thalamus is affected. Thalamus is synonymous with sensations, right? All the sensations, the relay center for the sensations. So what happens? There is contralateral hemisensory loss, followed by later the patient would be having a burning pain in the affected areas, right? So the pain is persistent and it responds poorly to analgesics. Sometimes the anticonvulsants can be beneficial. They might be beneficial sometime, right? So that is the Dejeron-Rousey syndrome. That is due to occlusion of the perforating branches of thalamic and thalamo-geniculate arteries, right? So that is about the P1 segment. That is the P1 syndrome, right? The proximal segment, P1 segment leading to the P1 syndrome, right? Now we will talk about the P2 syndromes. So the P2 syndromes include the distal part of the posterior cerebral artery, that is distal to the junction of posterior cerebral artery with the posterior communicating artery. Fine. So the P2 syndromes occurs when the cortical branches, right? So this will continue to give the cortical branches. When the cortical branches are involved, you will get the P2 syndromes, right? So you can see in this diagram the posterior cerebral artery. Where does it supply? It is the blue color, right? So it supplies the medial temporal as well as the occipital lobes, right? The medial temporal and occipital lobes are being supplied by the posterior cerebral artery, right? So once there is an occlusion of the distal posterior cerebral artery, what happens? This causes infarction in this area. Infarction in which area? In the region of the medial temporal as well as the occipital lobes, right? So there would be infarction in these areas. So what will happen if there is an infarction that is affecting the visual cortex, right? The occipital lobe is affected. So if the visual cortex is affected, what happens? There would be contralateral homonymous hemianopia with macular sparing. That is the usual manifestation, right? So why the macula is spared? Once again, it is due to the collateral blood supply that exists from the middle cerebral artery. So now when there is an involvement of the medial temporal lobe as well as the hippocampal involvement, what would be the feature? There would be an acute disturbance in the memory. But since the memory has got a bilateral representation, this usually clears itself, right? So that is the feature. Now if there is an occlusion of the posterior cerebral artery that is supplying the dominant hemisphere, right? The posterior cerebral artery that is supplying the dominant hemisphere is affected. That means the dominant hemisphere is affected. And if the infarct that it extends to involve the splenium of the corpus callosum. See, this is the splenium, right? This is the corpus callosum and this is the splenium of the corpus callosum. So if the infarct extends to involve the splenium of the corpus callosum, then the patient may experience a symptom that is called as the alexia without agraphia. That is, the patients, there will be alexia, that is the patients would not be able to read at all, and the patient often they might have a color anomia also, right? If you curiously look, they may have a color anomia, that is the inability to name the colors, but however they are able to write, that is alexia without agraphia, right? They are able to write but they are not able to read. So how does this happen? Let us see. See, this figure shows a left posterior cerebral artery occlusion. So this person is having the left hemisphere to be dominant. Here the left posterior cerebral artery is occluded. So what happens? The left posterior, the occipital cortex, the left occipital cortex is getting involved, right? So once the left occipital cortex is involved, what happens? There will be right homonymous hemianopia with macular sparing, right? So now, what is the special thing here? The splenium of the corpus callosum is also involved, right? Infarction extends to involve the splenium of the corpus callosum. So what happens now? The impulses which are reaching the right visual cortex. The right visual cortex is normal, right? So from the left visual field, the right visual cortex is receiving the impulses. Now these impulses could not be sent to the language area in the opposite hemisphere, right? So this is actually, there is a block here. Once the splenium is infarcted, these impulses from the right visual cortex is not able to reach the language area in the dominant hemisphere. So what happens as a result? The patient would be able to see, right, the words in the left visual field, right? The words in the left since the left visual field is intact, the patient would be able to see the words, but since the information cannot be transmitted to the or transferred to the language areas, the patient would not understand what the words mean. That is, he will not be able to read the words. That is alexia, right? But however, the person would be able to write. That is alexia without agraphia, right? So that is also due to occlusion of the distal posterior cerebral artery with involvement of the corpus callosum, splenium of the corpus callosum, right? So another important syndrome is the Anton's syndrome. What is it? If there is bilateral infarction in the distal posterior cerebral arteries, this will produce a cortical blindness. That is, there will be blindness with preserved pupillary light reaction. The pupillary light reflex is intact, but there will be blindness, right? Cortical blindness will be produced when there is a bilateral infarction of the distal posterior cerebral artery, right? So this results in a syndrome that is called as the Anton's syndrome. That is, the patients with this syndrome are cortically blind. They can't see anything, but they deny being blind, right? It is a form of anosognosia. It is a visual anosognosia, right? That is, they are denying that even though they cannot see anything, they will deny that being blind. Fine. So they don't accept their deficits. So that is Anton's syndrome. Now there is another important syndrome that is called as the balance syndrome. How does balance syndrome occur? It occurs due to bilateral visual association area lesions, right? If there is a bilateral visual association area lesion, this would result in a balance syndrome. So it is due to infarction of the watershed areas, right? What are the watershed areas? These are the areas that receive dual blood supply from the most distal branches of two large arteries, right? For example, this is the ACA and MCA watershed area. That is, it is receiving the dual blood supply that is from the ending branches, right? Most distal branches of two large arteries, that is ACA as well as MCA. So this area, in fact, the blood supply will be less compared to the other areas that are supplied directly by the artery, right? So that is the watershed areas. Now infarctions secondary to the low flow in these watershed areas, in the watershed area that is between the, here in case of balance syndrome, it is the watershed area between the middle cerebral artery as well as the posterior cerebral artery, right? So in the watershed area, if there is an infarction, this would lead to bilateral visual association areas, right? And visual association area lesions, and this causes balance syndrome, right? So what is the clinical feature of balance syndrome? The patient, they may experience persistence or recurrence of a visual image for several minutes even after the stimulus is removed. This is called as palinopsia, right? What is palinopsia? The persistence or the recurrence of visual image for several minutes even after the stimulus is removed, right? So that image will persist in the vision, right? So that is called as palinopsia. So palinopsia is a feature of balance syndrome, as well as the patients would also have inability to synthesize whole of an image. That is called as asimultanagnosia, right? Asimultanagnosia, that is inability to synthesize the whole of an image. So that is also a feature of balance syndrome. Why does it occur? Due to infarctions secondary to the low flow in the watershed areas between the distal PCA, that is posterior cerebral artery, and the MCA arteries, that is middle cerebral artery territories, right? So that watershed area is affected in case of balance syndrome. So that is about the posterior cerebral artery, right? Now we come to the vertebral arteries, right? Vertebral arteries as well as the PICA, posterior inferior cerebellar arteries. So embolic occlusion or thrombus formation in the vertebral artery, it causes ischemia of the lateral part of the medulla, right? It causes ischemia of the lateral part of the medulla, and this syndrome is called as lateral medullary syndrome, right? It's very important, can be kept as a long case also, right? So it is important that you need to check out for the symptoms of lateral medullary syndrome, right? So this is due to an embolic occlusion or thrombus of the vertebral artery. So the vertebral artery is the most common artery that is involved in case of lateral medullary syndrome. The second most common artery is the posterior inferior cerebellar artery, right? So what are the features of lateral medullary syndrome? Now let us take the rule of 4, which I have told you. So we can apply it on to here. It is the lateral part, right? So what are the features that should come here? What are the structures that should be there in the lateral part? The spinothalamic pathway, the sympathetics, the spinocerebellar pathway, and the sensory component of cranial nerve 5, right? Along with that, all the other motor nuclei other than 3, 4, 6 and 12 is lying in the lateral brainstem, right? So since this is the medulla, you know that last 4 cranial nerves are in the medulla, right? By this rule of 4, you know the last 4 cranial nerves 9, 10, 11, 12 are in the medulla, right? So 9, 10, 11 and 12 are in the medulla. So apart from these, what are the other nucleus that could be the 9, 10 and 11 nucleus, right? So that would be in the medulla. So this is how we are localizing the lesion, right? So what are the symptoms that the patient would have in case of a lateral medullary syndrome? See, the spinocerebellar tract is involved, right? So spinocerebellar tract that is present within the inferior cerebellar peduncle, right? This is the spinocerebellar tract in the inferior cerebellar peduncle, right? So spinocerebellar tract is involved. What will be there? There will be ipsilateral limb ataxia, right? Ataxia would be there on the same side. Now the spinal nucleus of cranial nerve 5 is involved. So what happens? There would be ipsilateral pain or temperature loss, right? So of the face region, trigeminal nerve that is innervating the face region, right? So there will be ipsilateral pain and temperature loss in the face, and the spinothalamic tract is involved, and this would result in contralateral pain or temperature loss. Fine, that is from the opposite half of the body. In fact, in case of lateral medullary syndrome, this is the only symptom that is occurring on the opposite side. All others are on the same side. So spinocerebellar tract, ipsilateral, on the same side there would be ataxia. On the same side of the face there would be pain and temperature loss. And on the same side, since the sympathetics are involved, there would be an ipsilateral Horner syndrome, right? Sympathetics or spinocerebellar tract, they do not decussate, right? So there would be ipsilateral, same-sided Horner syndrome. Then since the vestibular nuclei is affected, what would happen? There would be vertigo, nausea, vomiting, as well as nystagmus could be there, right? So and nucleus ambiguous, that is the cranial nerve 9 as well as 10 is involved. There would be ipsilateral paralysis of larynx, pharynx as well as the palate, and hence there would be dysarthria, dysphagia, hoarseness of voice, loss of gag reflex, and the palate, what I have told you in the previous video, right? The palate will droop on the affected side and the uvula will deviate away from the side of the lesion. That is, uvula will be pulled to the healthy side, right? So these are the features of lateral medullary syndrome, right? So this is how you are localizing the lateral medullary syndrome. Very important, remember that there is no hemiplegia in a patient with lateral medullary syndrome, right? So this you should keep in your mind. There is the corticospinal tracts are not involved. So there is no hemiplegia in case of a lateral medullary syndrome, right? So now we come into the medial medullary syndrome. It is due to occlusion of the vertebral artery or the anterior spinal artery, right? So now again let us apply the rule of 4, right? You have the motor pathway in the medial side, medial lemniscus, and medial longitudinal fasciculus, but that is not present in the medulla, right? That is present in the pons. The medial longitudinal fasciculus is a tract that allows communication between the third cranial nerve nucleus and the sixth nerve, right? So that is the connection that exists between the midbrain and the pons region. Now in the medulla it is not there. Then motor nuclei that divide the number 12. So in the medulla you have the 12th cranial nerve, right? So the corticospinal tract is involved. There would be a contralateral spastic paresis, and medial lemniscus is involved. So there would be dorsal column is involved, right? So there would be contralateral loss of proprioception, touch, pressure and vibratory sensations, and the 12th nerve nucleus or the fibers are involved. So there would be ipsilateral flaccid paralysis of the tongue, right? We have discussed about the lower motor neuron lesions of the tongue in the previous video, right, yesterday. So that is the 12th nerve nucleus. Fine. So that is the medial nerve. There is a medial medullary syndrome. Now we will come to the basilar artery, right? So in case of complete basilar artery occlusion, there is a terrible clinical condition that is called as the locked-in syndrome. It is actually a bilateral ventral pontine syndrome, right? That is affecting the ventral pons, bilateral lesions of the ventral pons once the basilar artery is occluded, right? In case of complete basilar occlusion. So what are the features of that? The patient would be having quadriplegia because of bilateral damage to the corticospinal tract, and the patient would not be able to speak because of the bilateral corticobulbar tract involvement, and the patient is incapable of any facial movements. Why? Because bilaterally the facial nerve is also involved, right? And then there would be limited horizontal eye movements. Why is it so? Because of bilateral abducens nerve and the medial longitudinal fasciculus involvement, right? And the vertical movements, only thing that is preserved is the vertical movements would be intact, as well as blinking also is intact. Why? Because the supranuclear ocular motor pathways are spared, right? So because of that, the patient would be able to communicate only with the vertical eye movements as well as blinking. And very important, remember that these patients have consciousness. They are not in a state of coma. Sometimes, the inexperienced clinicians, they often due to error, they might conclude the patient to be in coma, right? So this is not a coma. The consciousness is preserved. Why? Because there is no damage to the reticular activating system, right? So the consciousness is preserved. The patient is not able to move any muscle, right? So you can see this all are complete paralysis, right? Quadriplegia is the not able to speak. Facial movement is not the horizontal eye movement is not the right. So this is such a terrible clinical condition. So the intact vertical eye movements as well as blinking is the only one that is preserved, right? And consciousness is also preserved. Fine. So that is the locked-in syndrome, and this locked-in syndrome has got a very poor prognosis. With most of the patients, they die within an year due to respiratory failure. Fine. Now these are some of the other pontine syndromes, that is the Millard-Gubler syndrome, that is when the ipsilateral cranial nerve 6 and 7 are involved with a contralateral hemiplegia, right? And you have the Raymond-Fowell syndrome, that is the lower dorsal pontine syndrome, when the ipsilateral 6th nerve, the paramedian pontine reticular formation PPRF is affected, and 7th cranial nerve is also affected with a contralateral hemiplegia, right? So this is another two pontine syndromes. Fine. So that is about the posterior circulation strokes. Now we will come on to the management part, right? How will we investigate a case of acute ischemic stroke? So for an acute ischemic stroke, remember that non-contrast CT is the investigation of choice, right? What are the advantages of CT? One thing is that CT is easily available, it is cheaper, and it is better than MRI in case of detecting hemorrhages, right? So that is the advantage of CT. Now what is the disadvantage of CT? The disadvantage is that CT initially it is normal in case of infarct. The infarcts are detected after about 24 to 48 hours, and the CT also fails to detect small ischemic strokes in the posterior fossa, and also it doesn't define the ischemic penumbra. What is ischemic penumbra? I'll show you. See, once an infarct occurs, the core of the infarct is called as the umbra, right? This is the umbra, and this area is not salvageable. Around this area we have an ischemic penumbra, right? This area is salvageable. So our primary aim in the treatment is to salvage this area so that we can prevent the progression of the stroke, right? See, this is the core of the infarct or the umbra. The tissue is dead here, but here it is the ischemic penumbra. We have time to salvage this area. That is why we call the time is brain, right? In case of a stroke, as early as possible we should reach the hospital. Fine. So what are the early signs of ischemia in a CT? First sign is the hypo attenuating brain tissue, right? The brain tissue will be hypo attenuated, and this is due to the development of cytotoxic edema, that is due to ischemia, right? So that is hypo attenuating brain tissue. And then obscuration of the lentiform nucleus or blurred basal ganglia, right? So here you can see there is obscuration of the lentiform nucleus, or the basal ganglia is blurred, right? So this is seen in case of an middle cerebral artery infarction, right? So this is seen in middle cerebral artery infarction. This is the earliest and most frequently seen signs. Now another sign is the insular ribbon sign. That is, there is hypodensity as well as swelling of the insular cortex, right? There is hypodensity and swelling of the insular cortex. This is an early CT sign of infarction in the middle cerebral artery territory. Fine. And then another sign is the dense MCA sign. Here you can see this is the dense MCA sign. So a result of this comes as a result of a thrombus or a embolus in the middle cerebral artery. Fine. So you can see it on the CT angiography. The occlusion is visible here, right? So that is called as the dense MCA sign. That is due to a thrombus or an embolus in the middle cerebral artery, right? Occlusion. Now, this is an important message that need to be spread to the public, right? So to recognize the symptoms of stroke very fast, right? You have to think fast. To recognize stroke, you have to think fast. That is FAST. F for the face. You have to check if the face is drooped. This is for the common public, right? You have to check if the face is drooped. Can they lift both the arms? A for arms. Can they lift both the arms? Speech. Is their speech slurred? And do they understand you? And T is for time. Time is brain. Immediately reach the hospital, right? Now coming on to the treatment part, right? So treatment of an acute ischemic stroke. First of all, we will see the supportive treatment. Check the airway, breathing as well as circulation of the patient. First of all, you have to stabilize the patient, right? Check for the airway, breathing and circulation. The position, keep the patient in a 30-degree propped up position. This helps to relieve the cerebral edema if it is there. And what about the nutrition? If dysphagia is persistent, that is if it persists for more than 48 hours, then you have to start a Ryle's tube feeding. Fine. And then about the blood pressure, unless there is a heart failure or a renal failure and evidence of hypertensive encephalopathy or aortic dissection, you should not lower the blood pressure in the first week, as it may reduce the cerebral perfusion, right? So you have to be careful about the blood pressure. Do not reduce the blood pressure very drastically, right? So why we say so? Because normally, if in a normal person, even if there is a wide variation in the blood pressure of the person, the cerebral blood flow is not affected due to a process called as the cerebral autoregulation, right? So the cerebral blood flow is not affected, and once an infarct occurs, this autoregulation is lost, right? So if there is a drastic reduction in the BP, that will produce a relative ischemia of the brain, right? So the BP at presentation should not be lowered. If it is more than 185, 110, right, then you can give a beta blocker like esmolol. If it is very high BP, if it is more than 185, 110, then you can give a beta blocker like esmolol can be given, right? So that is about the blood pressure. Then if the patient is having fever, you can give antipyretics. Why? Because hypothermia will increase the infarct size. So you can give fever, you can give antipyretics to the patient in case the patient has got fever. And then the cerebral edema, it usually peaks on the second or the third day. Then for that you have to give IV mannitol. So that is the symptomatic treatment. Now about the specific treatment, right? So what is the specific treatment? The specific treatment for an ischemic stroke is thrombolytic therapy, right? So the only thrombolytic that is approved for treatment of an acute ischemic stroke is a recombinant tissue plasminogen activator, right? Recombinant tissue plasminogen activator, that is alteplase. Alteplase can be given for thrombolysis, but one important thing is that the window period to be given, that is the window period is the time of onset of symptom to the time of drug administration, should be less than 4.5 hours, right? So if the patient comes within the 4.5 hours with the stroke, then you can definitely go for thrombolysis using alteplase, right? Now the total dose of alteplase is 90 milligram. This has to be administered intravenously. It's 0.9 milligram per kilogram, right? So that is the thrombolytic therapy. So in addition to that, you can also use the antiplatelet agents like aspirin, clopidogrel, etc. can be used. Then the anticoagulation with heparin can be done. This is usually given in case of cardioembolic stroke, as well as if there is a history of transient ischemic attack, and also in case of non-septic venous thrombosis, right? You will give anticoagulation with heparin. So this is the treatment part of the stroke, right? Now we will come to the small vessel strokes. So these are the large vessel strokes which we were discussing about, right? So I think I will cover this topic also, that is the small vessel strokes or the lacunar infarction. So what are small vessel strokes? It is nothing but the atherothrombotic or lipohyalinotic occlusion of small arteries that range from 30 to 300 micrometers in the brain. Fine. And all the major arteries, let it be the anterior cerebral artery, let it be the posterior cerebral artery or the middle cerebral artery, all the major arteries, they give rise to such small branches that penetrate the gray matter or the white matter of the brainstem or cerebrum, right? And thrombosis of these vessels causes small infarcts that are referred to as the lacunes. So lacunes, it is the Latin word for a lake due to fluid that is noted at autopsy, right? So the infarcts, they range in size from 3 millimeter to 2 centimeter in diameter. Now what are the risk factors of a small vessel stroke? That is hypertension as well as age. Fine. Now there are some distinct clinical syndromes that are associated with the lacunar infarction, right? So let us see what are those syndromes. One is the pure motor hemiparesis, right? It is the most common lacunar syndrome. This results from infarction of the contralateral internal capsule, and sometimes the infarcts can be seen in the corona radiata as well as the pons also, right? So the face, arm and leg are equally affected, and there is no sensory loss, no homonymous hemianopia, no aphasia, no hemi-neglect, right? It is pure motor hemiparesis. The face, arm as well as the leg are equally affected, right? So that is pure motor hemiparesis. Now another lacunar infarction syndrome is the pure sensory stroke, right? So in case of pure sensory stroke, the infarction almost always involves the thalamus. So the sensory loss is present on the contralateral side, and the sensation is usually decreased for all sensory modalities, and no other neurological deficits are present. Fine. It is a pure sensory stroke. And the patient often complains of abnormal spontaneous sensations like pins and needles or skin tightness. So these are often the complaint of the patients with a pure sensory stroke. Now there is a sensory motor stroke where both sensory features as well as motor features would be there. That is, the infarcts involve both internal capsule as well as the thalamus is involved. Fine. Now another important thing is the ataxic hemiparesis, right? There would be a contralateral weakness as well as limb ataxia, and the weakness and ataxia would be present on the same side, with ataxia is more severe than that of the weakness. Fine. So the most common the lesion most commonly occurs in the pons, internal capsule or the corona radiata, right? Another syndrome is the Dysarthria Clumsiness syndrome. That is, there is prominent dysarthria as well as ataxia of the upper limb, and the facial weakness is the dysphagia, and there would be varying degrees of weakness in the arm as well as the leg, right? And this is associated with infarction in the internal capsule or the pons, right? So since we are always hearing about this ataxia, I will just tell you about the cerebellum also, just short. So, you know, the cerebellum is responsible for coordinating all the voluntary movements that is initiated by the motor cortex, right? So, when there is a lesion of the cerebellum, this results in an irregular, uncoordinated movements, right? This is called as ataxia. The irregular, uncoordinated movements that occurs due to a lesion of the cerebellum. Fine. So, cerebellum has got mainly three parts, that is the two hemispheres that surround the middle structure, vermis, right? So vermis is responsible. So what is the function of vermis? Vermis is responsible for the coordination of the central part of the body, that is the trunk, right? So the trunk region, for coordination, it is the vermis is involved, right? And the left hemisphere as well as the right hemisphere lesion would produce an ataxia of the same limb itself, right? So in the right hemisphere, the right upper limb and lower limb, left hemisphere, left upper limb and lower limb, right? So that is case of a hemisphere lesion, right? So what would be the lesion if there is a lesion in the vermis? In case of a lesion in the vermis, there would be truncal ataxia. What is it? The patient would involuntarily move their body back and forth. Why? Because they are constantly trying to stabilize themselves about their center of gravity, right? The balance is lost. So there would be truncal ataxia when the vermis is involved, right? So in case of cerebellar lesion, there are certain tests that you need to look for to find the cerebellar lesions, right? So what are those tests? That is, one is the finger to nose test. That is, you can ask the patient to touch the tip of her nose as well as touch the examiner's finger, right? So you have to do it rapidly, and then you can move your finger from one position to another, that is both sideways as well as towards and away from the patient, right? So that is finger to nose test. So what would be if there is a lesion in the cerebellum? That is, there would be a tendency to fall short or overshoot the examiner's finger. That is called as dysmetria or pass pointing. And once there is, in a case of a more severe case, there would be tremor, right? As the target finger is approaching the finger or the nose, right? Once the patient brings his finger towards the nose, there would be tremor, right? And also while touching the examiner's finger also there would be tremor. This type of tremor is called as an intention tremor, that is seen in case of cerebellar lesions. Fine. And another test is the rebound phenomenon, right? So in case of rebound phenomenon, you have to flex the elbow against resistance and release the resistance immediately. So what happens when you release? If the patient is unable to check the flexion of the elbow, that means it is abnormal. Usually the patient would be able to check the flexion of the elbow, but if the patient is unable to check the flexion of the elbow, then it is abnormal, and it is called as positive rebound phenomenon, right? And another important thing is dysdiadochokinesia. That is also a feature of a cerebellar lesion. That is, you are asking the patient to do a rapid alternating movement. Just like you can ask the patient to pronate and supinate the forearm immediately, right? Rapid alternating movements can be asked to done by the patient. So if the patient is not able to do this, then it is called as dysdiadochokinesia. Fine. Now, in case of the lower limb, you have the heel to shin test, right? So what is heel to shin test? The patient is lying in a supine position, and you have to ask the patient to keep his heel over the knee, on the opposite knee, and then slide his heel down to the ankle, up and down along the shin, right, between the knee as well as the ankle. So that is the heel to shin test. So that is equivalent test for lower limb. And what would be there if what is the abnormality? The patient would not, the heel of the patient would waver away from the line of the shin, right, from the line. You will not be able to do it perfectly in case of a cerebellar lesion. Fine. So in lesions, in disorders that are predominantly affecting the midline cerebellar structures. These examples include the tumors of the vermis as well as alcoholic cerebellar damage. So in this case, the test may be normal. Whatever test which we have said till now, these tests may be normal, and the only finding may be a truncal ataxia, right? So the only finding in such cases would be a truncal ataxia, and in most severe cases the patient cannot sit unsupported, right? And while in less severe cases, the patient would not be able to do a tandem walking. That is nothing but heel to toe walking. Heel toe walking, that is a tandem walking, right? So these are the important cerebellar signs that you need to know while you are examining a patient, right? So thereby we come to the end of the video. I hope this video series were useful to you. So something about the practical examination, that is, when you go to the practical examination, be confident and have all the examination tools to examine, especially the CNS kit and all, have it with you, and complete the case sheet within the given time, right? Usually you have only 45 minutes for completing the case sheet. So try to complete the case sheet as soon as possible. And in fact, this requires practice. A lot of practice is needed for that. So it is, if you take a case in the ward, while you are taking a case in the ward, just try to complete the cases, right? So this would give you enough practice for completing the case in the exam as well, right? Especially the multi-system cases, there will be more than one system that is involved, right? The patient having a hemiplegia along with a pleural effusion, right? So like these cases would be there in the exam. So when such cases come, if you want to complete on time, you should practice it before itself, right? And there is no need of any tension. Be confident before you go to the exam, right? Because tension is not going to do anything to you. It's not helpful to you. It's just going to ruin your confidence, right? So there is no need of any tension. So prepare the exam well and write the exam well. All the best for your exams. So please do give your comments, and also please do share the video. If you have been benefited from the video, definitely do share it, because let others also get benefited. So that's all. Thank you.